Is the screen visible now?
Yes, sir.
Okay. So I have just prepared it from Miller because I find that many of you are not following the textbook. You have other easier textbooks to follow. But the exams and examiners mainly want you to know something from Miller. So the entire presentation here is taken from Miller. And what I have understood from that, I'm just presenting. Ethics involving anesthesia practice can be categorized into clinical ethics and research ethics. That is how the topic is discussed in Miller. And what is clinical ethics? It includes informed consent, which encompasses competency or capacity of the patient, disclosure, what should be told to the patient, legal implications of the informed consent. Then informed refusal, how the patient can refuse, as Satipin said just now. Patient has the right to refuse any treatment, even if it is endangering his life. You can only counsel him and tell him that it is better that you undergo the treatment. But if he is very insistent that he does not want a treatment, especially in the end of life care, when they say do not resuscitate or do not try to save me, then it should be respected. And then special issues in informed consent, like Jehovah's Witness who refuse blood transfusion, pediatric other patients with impaired competence, or consent for lab testing for HIV and pregnancy, as I told you, maternal and fetal conflicts, and uncooperative patient coercion and restraint. These are all special issues where getting informed consent or informed refusal may be problematic. Then advanced directive and surrogate decision makers. This is another thing which is the patient's mental capacity. For example, a patient with Alzheimer's or dementia, he has fallen down and had a fractured femur, and it requires a fixation. The patient himself cannot give consent. So you have to depend on the relative, blood relative like son or daughter, who is taking care of that. And they are called surrogate decision makers. So in that situation, it is accepted that their decision can be followed and respected. And once you establish that the patient has got the proper mental capacity to make a decision. So, and how to treat them, all that has been seen in the earlier version of informed consent law. I think we discussed it in a class about last year for the earlier batch. And the end of life decision making, that is also part of the ethical concerns. And ethical issues in organ donation is about after brain death and after cardiac death. And research ethics consists of human subjects research and animal research, ethics on animal research. Now, going through one after another, the informed consent is a written consent in legal term that implies autonomous informed authorization by the patient to undergo a medical or surgical treatment. And it includes proper discussion between physician and patient. This is very, very important. You cannot just show the consent form, get the signature, and start treating the patient. You must sit with the patient and discuss with them and explain to them all relevant aspects of the treatment, and if there is any alternative, and answer all the questions asked by the patient. And the 5 essential components are disclosure, transmission of proper information to make a proper decision. The patient must be informed about the following components: nature of the disease, options available for treatment, success and failure rate after acceptance and prognosis, and cost of treatment. These 4 things have to be informed to the patient. Second is comprehension. An informed consent may be well understood by the patient. That is very important. It should be explained in his own language. So this is very, very important. If you do not know the language, you must have a proper interpreter who will disclose whatever you are saying to the patient and make him understand that. And if he has any communication problem, like if he's deaf, dumb, or blind, special attention will be taken that he understood everything properly. The third thing, absence of outside control. With informed consent, treatment should be given by the patient without any influence from others, either the doctor or nurses. You should not force him. For a hernia patient, you should not say, if you don't get operated, you will get strangulated and you will die. Like that, it's also a part of coercion to try to threaten him. So all that should not be done. And if a patient voluntarily asks for advice, so if you're supposing a hernia patient asks, doctor, what will happen if I don't get operated now? Then you can say gradually the hernia size may increase and it may one time now it is reducible, it may become irreducible, it will get strangulated. Then you may have to come and get admitted as an emergency, and it will be more riskier than to do it now. Like that, you can answer if the patient asks. Otherwise, as a course disease, you can explain to the patient in the earlier discussion. But anything which is frightening or which is coercing should not be revealed to the patient. And competence, the consent of the purpose for clinical examination, diagnosis, and treatment be given to any person who is conscious, mentally sound, and above 18 years of age. So that is called the competent patient to understand this. One patient should be fully conscious, mentally sound, and he must be an adult. And patient should not be under the influence of any drug, alcohol, or anesthesia. And lastly, is actual consent. To make it actual and legally acceptable, everything must be in writing. The signature of the patient must be obtained in the presence of two independent witnesses to avoid disputes over legal admissibility. Now, patient and witness should write their names below their signature, and relationship between them to be specified. If patient is illiterate and he puts only a thumb impression, then the name should be mentioned below the thumb impression. And consent should be for a specific procedure. If any other procedure is required, you should get a fresh consent. For example, you do a surgery, intraoperatively there is a problem, and you have not told the patient earlier or got the consent for that, then you have to inform the relatives in the middle of the procedure, explain to them, get their consent as a surrogate. Or if you are doing a regional technique and patient is conscious, you can inform the patient and you have to get a fresh consent for the added procedure. So nowadays what hospitals do is they put it in even in the primary consent itself. They say, I consent for the procedure that is explained, and in case if needed, any other procedure is needed, I consent for that also. They include that clause and take the consent so that they don't have to struggle getting the consent again for the unexpected procedure which lands up in the during the primary procedure. Then the second thing is informed refusal. So informed consent is meaningless if the patient cannot refuse medical treatment. So they give the ethical considerations give equal opportunity for patients to refuse their treatment also. The examples are request to withdraw or withhold supportive, especially in ICU treatment. This will happen. You say there is no scope of the patient recovering, then the patient himself may say, you can send me home. And invariably, hospitals may say you are taking your own risk and going against medical advice. But the patient has the full power to say that he doesn't want the treatment, and he can either withdraw or withhold the treatment, or do not resuscitate me if I suffer a cardiac arrest. That sort of power is there for the patient. And one of the special cases of informed refusal is Jehovah's Witness. And again, also patient can refuse lab testing. Coming to maternal and fetal clamps, rights of pregnant women to refuse treatment if the fetus is non-viable is accepted by law, even if it can result in abortion. Okay? And what about the uncooperative patient? When faced with an uncooperative patient, adult patient, following questions need to be asked. Is the patient clearly incompetent or merely angry and uncooperative? Or is there evidence of neurological impairment or acute intoxication or severe mental disability? So make sure there is no functional disability in that patient. If the patient is in immediate danger, Does the patient pose a direct threat to staff or other patients in the hospital? Is there a compelling need to treat life-threatening injuries? In the absence of these conditions, use of coercion, physical or chemical restraint is unethical and illegal. So, if the patient is uncooperative and combative, if the treatment is life-saving, then you can restrain the patient and go ahead and treat. Otherwise, and before that, you must rule out that he is only doing it as a behavior and not because of some underlying disease process. Okay, so this is what the uncooperative patient treatment ethics concerns. Now, coming to competence and decision making, competence refers to legal authority to make healthcare decisions, and most of the states or patients are considered as competent. If a patient is minor, generally parent or legal guardians will be coming to help them. And depending upon the state law, this allow sometimes minor also can give consents. That is in the United States. Some there are so many states in the United States. So that is why it's called the United States. In the, each state has got its own independent law and judiciary system. So some they allow even 14, 15 year kids who are mentally sound, they can give consent. So emancipated by court or married or engaged in military service, living independently from their parents, all these patients can give consent if they are high school graduates or if they have already become parents and they have a school, which are all common in the United States, and seeking specific types of healthcare treatment like pregnancy related mental health, drug and alcohol abuse. So all these patients are allowed to give consent. Minors can consent to care. That is what is the United States law says. And decision-making capacity is one which is not to be confused with competence or legal authority. So decision-making capacity refers to patient's ability to make a meaningful decision at a specific time, because these are all legal jargons that will be a little more confusing than our regular language. So whether or not to undergo anesthesia, including appreciating the significance of anesthesia plan care and its potential consequences. So the anesthesia professional evaluates the patient and determines the capacity to make specific healthcare decisions. And the patient relieves anxiolysis or analgesics, then they must be taken proper care to seizure. And if necessary, you can do a mini mental state examination in the elderly patients who are little confused or not coherent. Then document the determination of the patient's decision-making capacity. Patients who are become incapacitated have the right to have the decision-making authority transferred to a legal decision maker or some so-called surrogate decision makers. So a patient can delegate this right to other person in accordance with the state law again. And the designation continues throughout the patient anesthesia care unless express withdrawn. So the patient, if he says somebody else will, for an elderly 80-year-old patient who is deaf, who can't hear a word, and he says my son will take all the decisions on my behalf. So the son becomes the surrogate or legal decision maker, and you tell the surgeon whatever you are going to do and get his consent. Unless the father says, no more my son will be my legal decision maker, that initial acceptance will be holding good. But once there is some conflict between father and son, and father says, I don't want my son to take decisions, and gives in writing saying that my daughter will take the decision, then this first consent given to the son is considered withdrawn, and the new surrogate decision makers decision will hold good. So unless expressly withdrawn either orally or in writing by the patient, that initial legal consent given to the surrogate decision maker will hold good. Now coming to disclosure information, the anesthesia professional provides the information that is relevant and helpful in making a decision. And informed consent begins with explanation of the patient's decision-making role, and then interactive process of communication about alternative risk, benefits, everything should be explained to the patient. And if applicable, the anesthesia care about goals of care, possible recovery concerns, and post-anesthesia period are also discussed. For example, a child coming for strabismus surgery, you must inform the parent that there is a possibility of post-operative nausea and vomiting. But you can explain that we will try to control it by giving medications, but still there is a 10 or 20% chance that the child may be vomiting several times post-operatively. If this is not disclosed, then the parents have the right to find fault with the doctor and go for legal measures. That is where the whole problem arises. So it is better to disclose the possible care and recovery concerns and other things to the patient. Now, end of life decision making is another part which is given in Miller. So, end of life issues are control over timing and location of death, management of symptoms like pain, dyspnea, anxiety, etc., financial management of medical care, maintenance options for including physician assisted suicide. So in Netherlands, they have this opportunity for the patients who are suffering from non end of who are facing in their end of life with no possible treatment to cure them from a long-standing illness. They can seek the physician's help for assisted suicide also. And the patients have right to forego invasive treatment, even if it is life-saving. For example, if you want to put in a central line to treat a patient, and if the patient is mentally fit and if he says, I don't want that, you have to accept his refusal. Anesthesiologists also have a role in withdrawal or withholding therapy to patients in OR before organ donation. So if the family or if the patient himself has given consent to harvest the organs after his death, then you can continue the treatment or withdraw and withhold. But at the same time, it should not be like a hastened death just to retrieve the organ. So that is a small confusion there in that particular scenario. So organ transplantation after brain death is, before assuming care of brain dead donor, he should review the chart for documentation and declaration of brain death as well as the criteria on which it was based. If there are any questions about the diagnosis, organ donation, then you must wait and get it clarified before you proceed with the organ retrieval. Sometimes a patient will have given consent for harvesting the organ after the cardiac arrest and cardiac death also. Earlier, we were harvesting only from brain dead patients who were supported artificially with ventilation and fluid hemodynamic support. The relatives were giving the consent because the brain dead is unconscious. So the definition of brain death is irreversible consciousness and the inability to breathe on their own. That is the definition of brain death. So those patients cannot give a consent. So the relatives only have to give the consent for organ donation. Whereas for cardiac donation after cardiac death, a patient who knows that he has a very critical cardiac illness from which he cannot be retrieved or saved, that patient can give while he is alive, he can give a consent and declaration saying that you can harvest my organs after my death or after my heart stops. And this sort of patients may be in the hospital or they may be in their home where they die and immediately brought to the hospital. So you have time only up to 30 minutes in these patients to harvest the organs. So there the consent is given by the patient himself when he is alive. So donation after cardiac death, the patient agrees for withdrawal of life support therapies and wishes to donate organs after death. The decision is made before death after discussion and informed consent so that ischemia time is minimized. This is a very important role. And anesthesiologists involved in donation after cardiac death should have appropriate training and expertise in relevant ethical, legal, and medical issues involved in including the end of life care. And research ethics, human subjects must have the balance and needs for right to research, rights, research ethics, hypoethical future patients and physicians' financial, professional, and personal goals should not be the criteria for doing the research. And ethical conduct of human subjects research must follow three principles. One is respect for autonomy and obligation to protect subjects with limited autonomy. Beneficiaries that with the obligation to maximize benefits and minimize risk by ensuring sound research design. Justice obligation to treat each person with regard to what is morally right and ensure fair distribution of benefits and burdens. So when you want to do a human research by comparing a drug for hypertension between two groups of patients, you must tell the patient about all the good and bad effects of the drug, how you are trying to do. So many patients, especially in anesthesia, when we try a painkiller, you cannot try between a placebo and a painkiller for treating a pain condition. It should be between two painkillers to see which one is more effective. So that sort of ethics you should follow. You cannot just say I will give this water injection and tramadol injection and compare the results. That is not fair. So these are the things that are mentioned in this. And disclosure in human subjects research should not only include risk and benefits, but also possibility of commercialization of the results. That is, once you, especially with the pharmaceutical companies coming out with the newer molecules or drugs, and when you try them on the human subjects for finding out the efficacy, once it is found that it is a quite efficient drug to treat a particular condition, it is going to be marketed and the company is going to make a lot of profit. So that commercialization also possibility should be revealed to the patient. The financial interest of the researchers also should be, that is the ethics in research. And any conflict of interest on the part of researchers and their institutions or sponsors, everything should be revealed to the patient. And monetary or other inducements to participate in research are permitted if they do not undermine the freedom of the subject. That is, you can entice the patient by giving, say, if you participate in this research study, we will take care of your stay in the hospital, your food and other things. You need not pay any amount, and you will pay, your transport will be taken care of. So all these niceties can be told. But if the patient feels far halfway through the research project that he doesn't want to participate anymore due to valid reasons, then he must have the freedom to withdraw himself from that. So that is also part of the ethics. And researchers must follow the doctrine primum non nocere, that is, first of all, do not do any harm, try to maximize the benefits to subjects. And the findings must be promptly and accurately reported. And research must be terminated immediately if it is suspected to be harmful to participants. The interest of individual subjects always prevails over the interest of the society. So if it is going to harm the subjects whom you are doing any research, it should be immediately stopped, even though that research may benefit the society at large. Then child as a research subject, if a minor child 7 years or old is able to assent must be obtained from them also, in addition to the legal surrogate decision makers like parents. So if a 7-year-old boy is smart enough to ask you questions, what are you going to do on me? How I am going to be? Is it be painful? Will I be having any problem? All that, if he is able to ask and he is mentally sound, you must convince him and get his consent also, apart from the parents' consent. And coming to ethics of animal research, they have the same obligation like what you do for a human being. So proper human considerations and appropriate veterinary freedom should be given to that. Researchers should keep in mind 3 R's while doing the animal research. One is replacement, second is reduction, and third is refinement. This means using animal subjects only when necessary, minimize any suffering incurred in the study to the animals, seek nominated replacements for animal subjects. Okay, so these are the things that are given in Miller, which I have compiled. So whatever Satyapriyan has prepared, and this both combining both, you can formulate your own method of answering this question. Okay.